Welcome back to The Explainer. Today, we're tackling one of the fastest growing yet most heavily scrutinized areas in medical coding. If your practice is utilizing remote patient monitoring or remote therapeutic monitoring, you already know these services are absolutely incredible for patient care. But from a billing perspective, well, they're a literal minefield of complex CPT guidelines. One wrong code or one missed documentation requirement, and you've just triggered an audit. So today I'm putting on my medical coding instructor hat to give you the exact step-by-step blueprint to navigate these digital health codes safely, accurately, and confidently. Here's exactly what we're going to cover today. We'll start with the basics of RPM versus RTM, move into device setup and supply, break down the critical 16-day data rule, look at treatment management time tiers, map out co-billing overlap rules, and finally wrap up with the top audit red flags you need to avoid. Let's get right into it. Starting off with Section 1. RPM versus RTM basics. What exactly are we actually monitoring here? To lay a really solid foundation, we first have to establish the critical distinction between the two main categories of remote monitoring. Because look, if you don't know what kind of data you're looking at, you absolutely cannot select the right code family. It all comes down to the rule of contrast. RPM, or remote patient monitoring, is exclusively for objective physiologic data. We're talking about hard numbers that are automatically transmitted by a digitally connected device, things like blood pressure, heart rate, pulse oximetry, or blood glucose. On the flip side, RTM, or remote therapeutic monitoring, handles non-physiologic data. This includes tracking a patient's respiratory system status, musculoskeletal system status, their therapy adherence, or pain levels. And unlike RPM, which has to be automatically transmitted, RTM data can actually be self-reported by the patient or collected by a device. Now, the most crucial point to remember is that medical necessity has to drive the use of RPM. You can't just hand a patient a blood pressure cuff because it's a cool piece of tech. You have to be actively managing an acute or chronic condition that specifically requires continuous or periodic clinical oversight. And there's another major catch. The device you use must be defined as a medical device by the FDA. If it doesn't meet that FDA standard, it doesn't meet the CPT criteria for RPM. It's that simple. Moving on to Section 2, device setup and supply, or what we like to call the hardware phase. Now that we know exactly what kind of data we're dealing with, let's look at getting the patient properly equipped and educated. Think of this as a two-step linear progression for billing the technology itself. Step 1 is the initial device setup and patient education. If you're doing RPM, you're going to bill CPT 99453. If you're doing RTM, you bill 98975. This covers the time your team spends showing the patient how to turn the device on, how to wear it properly, and how to make sure their data is actually transmitting. Then we hit Step 2, the actual device supply and daily recording code. For RPM, that's CPT 99454. For RTM, it's 98976 for respiratory data or 98977 for musculoskeletal data. So the workflow is, you build a one-time setup code first, followed by the monthly device supply code for the daily recordings. If you look closely at the actual AMA CPT guidelines straight from the sourcebook, check out the text right underneath code 99453. There are some very strict parenthetical notes there. It explicitly warns us not to report 99453 more than once per episode of care. Remember, an episode of care begins when the remote monitoring is initiated and ends when the targeted treatment goals are met. So you do not build that setup code every single month. It is strictly a one-time service per episode. All right, Section 3 brings us to the 16-day data rule, the critical data threshold you have to hit. We are now entering the territory of a major compliance trap. This is the exact spot that trips up countless practices during revenue cycle audits. 16. This number represents the absolute minimum days of recorded or programmed alert transmissions required within a 30-day billing window to report your device supply codes like 99454. It's not an average. It's not a suggestion. It is a hard numerical threshold. To be absolutely clear about this, let's look at the exact guideline rule. If you only collect 15 days of data, you cannot bill the device supply code for that 30-day period. Now, I know during the public health emergency there were some CMS flexibilities that allowed for fewer days, but those days are gone. You need 16 distinct days of data transmission in a 30-day window to legitimately drop that claim. If your patient gets annoyed, takes the device off for 2 weeks, and you only get 14 days of data, that month's hardware supply code is simply not billable. Next up is Section 4, Treatment Management Time Tiers. This is where we bring in the human element. Okay, So once the hardware is transmitting data and you've successfully hit your 16-day threshold, the work still isn't done. Now we have to calculate and accurately bill for the human element, the clinical staff, physician, or qualified healthcare professional time spent actually managing that patient's care based on the incoming data. This table maps out the 20-minute tiered structure beautifully. I love this layout because it constantly contrasts your base codes against your add-on codes to keep all the numerical jargon organized. For RPM, your base code for the first 20 minutes of treatment management time in a calendar month is CPT 99457. If you spend an additional 20 minutes, meaning you hit 40 minutes total, you attach the add-on code 99458. For RTM, the concept is exactly the same, but you use different codes. 98980 for the first 20 minutes and the add-on 98981 for each additional 20 minutes. But here is a massive detail you cannot overlook. Looking directly at the source code text for 99457, notice the strict requirement embedded right there in the descriptor. It requires at least one real-time interactive communication with the patient or caregiver during the calendar month. This is huge. You cannot just sit at your desk, review the data silently, document it in the EHR, and then bill for the time. To cross the finish line for these management codes, your clinical staff or provider must have at least one real-time synchronous interactive communication, usually a phone call or a video chat, with the patient to actually discuss the data and their treatment plan. That takes us to Section 5, Co-billing and Overlap Rules. Time to set up our guardrails. Let's talk about high-stakes guardrails, because when you have a chronically ill patient, you're likely providing multiple care management services simultaneously, and overlapping these services is exactly where auditors love to dig in. You absolutely can co-bill RPM or RTM with other care management services like chronic care management or CCM and principal care management, PCM, in the exact same calendar month. However, the time spent must be completely distinct. There is absolutely no double dipping allowed. If a nurse spends 20 minutes reviewing blood pressure data and calling the patient for RPM, those 20 minutes belong exclusively to 99457. You cannot take those same 20 minutes and apply them toward your 20-minute threshold for CCM code 99490. You would need a total of 40 distinct minutes to bill both. Furthermore, the guidelines prohibit billing RPM and RTM concurrently for the exact same target data set in the same month. You just have to pick the most appropriate framework based on the primary clinical focus. Finally, Section 6, Top Audit Red Flags. Consider this your practice's compliance checklist. To wrap up this compliance blueprint, let's look at the top vulnerabilities that auditors actively search for to instantly fail a claim and demand a recoupment. Treat these rapid-fire bullet points as your ultimate daily checklist to ensure your practice isn't making costly, avoidable errors. First, if your logs show 14 days of data but you billed 99454, you fail. Second, if you billed 99457 for 20 minutes of time, but there's no documentation of a real-time phone or video call with a patient, you fail. Third, if the device isn't FDA defined, it doesn't count. And finally, if your time logs don't clearly separate your RPM time from your CCM time, auditors will automatically assume you double counted and you will lose that revenue. Through all these complex time thresholds and coding nuances, never forget the golden rule of coding, defined right here by CMS, medical necessity. Just because a patient happens to have a shiny new digital device, or just because they like seeing their health stats on an app, doesn't mean you can bill Medicare or commercial payers for it. The ongoing monitoring must be clinically justified, directly tied to an active diagnosis, and strictly necessary for their specific ongoing treatment plan. So I want you to take a hard look at your internal workflows today. Ask yourself, are you tracking those 16 days rigorously? Is your clinical staff documenting those interactive phone calls every single month? Because one weak link in this chain isn't just a simple coding error. It's an open invitation for a massive audit recoupment. Turn this compliance risk into a seamless, highly effective extension of your patient care. That brings us to the end of our blueprint. Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.